Um, so is state level single payer a viable endeavor is the title of my talk. And I have no conflicts of interest to disclose. Okay, so what's wrong with our current health insurance business model and how could single payer solve these problems? Competitive insurance means you have a fragmented risk pool, and this risk pool is split up among different competing organizations, each of which has an incentive to avoid financial risk, which means avoiding either covering or paying for sicker, more socially disadvantaged, and more complex patients. And this is supposed to be corrected with risk adjustment, but that's very complex. The best formulas only capture about 12% of the variability in cost. So the risk adjustment formulas are utterly ineffective in preventing cherry picking healthier patients by risk-bearing entities. And also insurance companies or provider groups that have insurance risk game diagnosis codes to beat risk adjustment formulas by upcoding people to make them look as sick as possible so they can capture a higher payment. The result is disparities in access to care and high administrative costs. And the administrative costs include the cost of competition, the cost of risk, and this is, there's ups and downs every year in the cost of healthcare and, and the claims that come in. And if the insurance company is bearing the risk, then they say, okay, you pay us and we'll cover that risk. We'll cover the ups and downs, but they make sure they charge enough in premium so they're very unlikely to lose money. And so anyone who's shifting insurance risk onto insurance companies or competing healthcare delivery systems that are bearing risk has to pay a premium for that convenience of pushing the risk onto someone else. There's the cost of a very complex payment system. This runs somewhere around 15% of gross revenues for physicians, around 15% of gross revenues for hospitals, and comparable amounts of money for the insurance companies or the government programs that are funding them. So it's a huge amount of administrative waste, as Michael Lady said. And there's also high administrative costs to the latest policy fad, which is value-based payment, which means shifting insurance risk onto doctors and hospitals. And that carries high administrative costs. In fact, we do not have a problem with overutilization. We have a problem with excessive administrative costs, much higher than in other countries. This is a famous PNHP graph, and I just want to point out the red is managers and administrators, the green at the bottom is physicians, and the growth since 1970s. And the steep jump in the 90s is the managed care era, when we brought in all these third parties who are supposed to make healthcare more cost effective. What they did is they added huge amounts of administration. And at the end, we have another bump, which is the value-based payment bump promoted by the Affordable Care Act, which has a new version of HMOs, which is ACOs, Accountable Care Organizations, integrated delivery systems, who are supposed to accept insurance risk. And that's resulted in another bump in administrators. And this is just comparing the US total administrative overhead of our system with Canada, a single payer system. And as you can see, it's about 4 times more administration here than there is there. And Canada doesn't even have single payer for drugs. They could save even more if they included drugs in their single payer program. So single payer enables a single risk pool, a non-fragmented risk pool, universal access to the same care delivery system for everyone. And it allows us to pay hospitals with global operating budgets instead of using fee-for-service. And this eliminates gaming of diagnosis, and it eliminates the incentive for unnecessary care. And it saves 15% off the top. And it allows us to pay doctors with a simplified, standardized payment system that does not cost 15% of revenues and similar costs on the payer side. We could design a physician payment system that's either salaries for physicians employed by hospitals or community health centers or things like that, or a more incentive neutral version of fee-for-service that would be much less expensive to administer. And we can enable collective negotiation of fees, which they do in Canada, and which provides good balance between the interests of physicians and the interests of taxpayers and society in keeping healthcare affordable. So how can state level reforms advance single payer goals? We can start with the components of the healthcare system that are under state control, which is state and county employee and retiree health benefits and Medicaid. And these are typically around 30 to 40% of a state's budget, and they cover around 30% to 40% of a state's population. If a state were to kick insurance companies out, as Connecticut did with Medicaid, and I'll get into that a bit more later, if states were to self-insure these two programs and eliminate competing risk-bearing insurance plans, they could get control of the payment system, simplify, standardize it, so you would have the same payment system, the same fees across Medicare and employer benefits, Medicaid and employee benefits. And that would result in substantial administrative costs to the state. And you can use non-risk administrative services only contracts for necessary administration, for claims processing, for credentialing, for things that you need to do administratively in a single payer system. But the key is they're non-risk bearing. So you're not saying, here's the money, you take the risk. We're saying, we'll take the risk for paying the claims, but we want you to do these specific jobs and we're contracting with you to do those jobs. Dealing with ERISA. Actually, I missed a slide back at the beginning. Hold on a sec. Okay, yeah, I missed this slide. We agree a national single payer system would be ideal, but there are two major obstacles. One is capturing the money for federally funded programs like Medicare, the VA, Indian Health. And the second is the ERISA law, which exempts self-funded employer and union-based health plans from state insurance laws and regulations. So that this is on what to do about ERISA. So I think the best solution to ERISA, Hawaii has an ERISA waiver, but I think we're in a unique situation because we had just passed a law called the Prepaid Healthcare Act, which has an employer mandate, and that would be a violation of ERISA. And they passed the ERISA law a couple of months later, and our Senator Noy persuaded Congress to give us an exemption to ERISA so we could implement the law that we passed.
Sorry, yeah. I think the slides screen sharing was lost.
Okay, let me see if I can find that. All right.
Perfect, thank you.
Okay.
Yes. Perfect.
So if we bypass ERISA and say, we're going to establish a universal tax funded healthcare system that covers everyone in the state, let self-funded employers and unions continue their plans if they want to. So we're not messing with ERISA. You can continue to have your own plan, but since they all have to pay taxes, they'd be paying for healthcare twice. Very few unions or corporations would put up with that. They would very quickly, as long as the public plan was good, they would quickly drop their ERISA plan and take advantage of the public system. So I think this is the way around ERISA. You just go around it. You don't try to fight with it. Okay, why states should avoid shifting insurance risk onto doctors and hospitals. So insurance is a system for managing financial risk, and it's designed for risks that are infrequent, expensive, and unpredictable, like lightning striking your house and having it burn down, stuff like that. That's what insurance is ideally designed for. And the main way of managing risks that meet all these three criteria is risk pooling. Everyone contributes a little every month, and the unlucky person who has their house burned down then has the money to cover it. And we all share in the risk and spread it across a large population. That's risk pooling. That's the valuable part of insurance. The extent that risk is predictable, then the insurance business model uses underwriting, which is trying to analyze where risk is predictable so that they can either refuse to cover it or charge more for it. And this undermines the whole purpose of health insurance. And the problem with healthcare is way too much of the risk is predictable. We have pre-existing conditions, demographics, social determinants of health. Way too much is predictable. So when you apply the insurance business model in healthcare, you get a very strong incentive to avoid risk. So who has risk? It's whoever has the money and is stuck with covering the ups and downs of healthcare costs. And it means that there's an opportunity for profit or retained earnings and a risk of loss. And the clearest example is capitation, where you're paid per member a fixed amount of money to cover healthcare. And if you spend more on healthcare than that money, you lose. And if you don't spend that much on healthcare, you get to keep the difference. That's what capitation means. That's what a risk-bearing entity is. And it also includes any payment scheme that holds providers of care accountable for the cost or outcomes of care, which depend largely on patient characteristics that are beyond their control. So an insurance risk-bearing entities has specific enrollees or assignees or members, and is paid by the enrollee or assignee or member, and has a contract obligating them to cover all medical care for those members. This includes HMOs, ACOs, integrated delivery systems, and capitated doctors. Okay, the rationale for risk shifting in healthcare is that the theory is excessive US healthcare costs is because fee-for-service provides an incentive to maximize volume of care. And so we supposedly have a lot of overutilization due to fee-for-service. So if we flip the incentives and pay doctors or systems upfront to cover the cost of care, then their incentive is to only deliver care that's truly necessary and not deliver unnecessary care. This requires big data to analyze risk. Ultimately, it's for the purpose of avoiding risk or charging more for it, but you need a whole lot of detailed information in order to manage risk. The problem is the premise is false. Utilization of care in the US is toward the low end of industrialized countries that cover everyone for half what we do, usually using fee-for-service. There's no evidence of excessive utilization in primary care paid with fee-for-service. I've never seen any studies showing that anywhere in the country. There are perverse incentives when you shift insurance risk. You have an incentive not to deliver unnecessary care, but you also have an incentive to skimp on necessary care and to avoid sicker, more complex and socially disadvantaged patients that might cost more. And the counter incentives are pay for outcomes, which exacerbates the incentive to cherry pick, and risk adjustment, which is way too complex to do accurately. And if you try to make it more accurate, it results in a prohibitive administrative costs and burdens. This is a study showing that doctors who are being subjected to insurance risk quickly abandon private practice and go to work for bigger organizations like hospitals that can afford to take on that risk. The hospitals have the clout to force higher fees, and they do. Primary care physicians employed by hospitals charge Medicare 78% more than independent primary care doctors, specialists 74% more, and surgeons 224% more. And this is an accelerating trend of doctors moving to employment by hospital systems, and it's resulting in higher costs for everyone. Okay, what is happening to healthcare reform in Hawaii? Okay, in 1974, we passed the Prepaid Healthcare Act, which has an employer mandate, and we got an ERISA exemption for that. This means we've had broad coverage of the population since '74, mandated comprehensive benefits, no pre-existing condition exclusions, and no deductibles. And copays are limited to 10 to 20% of charges, which is like the ACA Gold and Platinum level. And we had mostly small independent practices paid with fee-for-service. And this is in place from '74 until the Affordable Care Act. As of 2008, we had the best benefits, the broadest coverage, and the best access to care in the whole country. Our dominant insurer standardized and controlled fees, so that was similar to what single payer could do, and kept the payment system relatively simple. They prided themselves on having among the lowest administrative costs of any insurer in the country. There are minimal controls on utilization. We had among the lowest administrative costs in the US and among the lowest commercial health insurance in the premiums in the US. So we had by far the most cost-effective system in the country. And our per capita Medicare costs were also the lowest in the US. So with the Affordable Care Act, we are told, you're doing everything wrong, you're using fee-for-service, you need to do something different. They should have listened to what we were doing and had the rest of the country follow us. So HMSA is our dominant insurer, and they jumped on board the value-based payment bandwagon. They have not engaged in risk avoidance because they have too big a market share to do so, but all their competitors do. They market to healthy people. They have unfriendly policies to complex patients. They tend to set up shops in wealthier neighborhoods. They have ways of gaming the risk pool so they get a healthier than average risk pool. HMSA is stuck with the rest. So they latched on to the idea of value-based payment because it would enable them to push the risk onto the doctors instead of them being in that role. And then doctors have the incentive to avoid sick people and to skimp on care. And also doing this requires a large amount of data. And so HMSA says, oh, we can do that. We're an insurance company. We can get detailed data for risk adjustment, detailed data for quality measures, this kind of stuff. So this means high administrative costs, and it's driving doctors out of practice into appointment by hospitals who can raise prices. And they don't care because they can get away with raising premiums as much as they need. And administrative costs can be hidden. And this is something that you need to understand. In 2011, after passage of the Affordable Care Act, the insurance industry negotiated with the Obama administration to classify medical management as healthcare, not administration, for calculating how much of the healthcare premium goes to healthcare versus administration. So anything that they can call medical management, which is quality improvement, utilization management, payment reforms that are supposed to save money, all those things, they can stop classifying them as administrative costs and classify them as healthcare. And this includes the cost of payment reforms that have the goals of assuring appropriate utilization, controlling costs, or improving quality of care. And all that matters is the stated goal, not the actual outcomes. It doesn't matter that almost all the recent innovations in medical management have resulted in increased costs, declining access to care, worse metrics. It doesn't matter that the effect is the opposite of the goal. As long as the goal is these things, they can call it healthcare, not administration. This is a study that showed if you calculate administrative costs the old way, where medical management is administration, there has been no reduction in administrative costs by insurance companies since the Affordable Care Act. It has done nothing to slow the administrative overhead. They're just reclassifying as healthcare and playing games with their accounting. So HMSA, HMSA, hold on a sec. Did you lose screen sharing again? Oh, I am still screen sharing. Okay. Looks like we're okay. Okay, HMSA capitated primary care practices in Hawaii, and they tried to do it with all of them, although they weren't always able to include the hospital clinics in 2017. And they then had a study that was published in Journal of AMA in July 2019 on the first year of this program. And they were looking for cost savings, improvement in quality, whether or not the program achieved the goals of payment reform. And they found out that there was a substantial reduction in primary care visits, but the primary care doctors are paid a fixed amount per patient per month, whether they see the patient or not, so that saved no money. Slight increases in referrals to specialists, urgent care in the emergency room, and basically no difference in the total cost of care. And they did have some improvement in quality metrics, but those metrics capture maybe 2% of what doctors do. So I think they're of limited meaning. And the study failed to mention medical management administrative costs for both the insurer and for doctors, which everyone on the ground knows increased substantially. This is a survey done of Hawaii physicians at the end of 2019, just before the pandemic, a couple of years into the program. 80% felt it caused an increase in administrative tasks. 42% reported reduced gross practice revenues plus increased overhead. 80% felt it contributed to worsening physician shortages. PT is payment transformation or capitation. And 80% would not recommend a new physician starting practice in Hawaii. And we've been losing doctors rapidly. We're now 1,000 doctors short for our population. So self-insuring Medicaid. Medicaid, as you probably know, is a joint federal state matching funded program, roughly 50-50 in wealthier states, but there's some fund transfer from richer to poorer states. It's managed by the states, who get to determine how the program is structured, and there's quite a bit of variability from state to state. There's temporary aid for needy families, Medicaid expansion population, and aged, blind, disabled, those who qualify for Social Security disability that are included in Medicaid. Starting in the mid-90s, states started turning Medicaid over to private insurance companies using Section 1115 waivers. These are called MCOs, Managed Care Organizations. Most started with aid for dependent children or temporary aid to needy families and general assistance, and some have expanded to aged, blind, disabled. By 2017, 2/3 of Medicaid recipients all over the country were under MCOs. The goals are supposedly budget predictability, save money, improve coordination and quality of care, more flexible benefits, network management, and improved payment schemes. Okay, 40 states contract at least, oh no, we got this, all right. All right, the only states to implement Medicaid managed care using full risk health plans and then switch from that to self-insurance with primary care case management are Oklahoma and Connecticut, and both achieve significant savings. Primary care case management means you pay primary care doctors extra to manage and coordinate care instead of hiring an insurance company to do that. You pay the doctors directly an extra fee, and you enhance primary care pay, and you say you coordinate care. They're in a much better position to do that because they know the patients. The insurance company obviously doesn't. Oklahoma achieved savings, and they also achieved an significantly improved physician participation. And Oklahoma did primary care case management in part of the state and MCOs in part of the state. And they found that the primary care doctors were doing a lot better than the MCOs, so they fired the MCOs. Connecticut noted that experience and implemented primary care case management throughout Medicaid in Connecticut in 2012. They've also followed the lead of North Carolina, which developed the enhanced version of primary care case management with more community-based extra services for complex high-risk patients. So Connecticut used the North Carolina model based on the experience of Oklahoma, and they kicked the insurance companies out and self-insured Medicaid and hired one of the former managed care plans as an administrative services only contractor in 2012. Prior to 2012, full risk Medicaid managed care organizations, the cost to Connecticut rose 45% over 4 years. That's over 10% a year. After 2012 and converting to an administrative services only contract, physician acceptance of Medicaid went up by somewhere around 25 or 30%. ER usage dropped 25%. Hospital admissions and readmissions dropped 6%. And 6 years later, per member, total Medicaid costs were 14% lower in 2018 than in 2012. And administrative costs were running 15 to 40% for the Medicaid MCOs. They run 12.5% for Connecticut commercial plans, and they're now 2.8%, including the cost of the administrative services only contract. This is a much better result than anyone expected when they made this move to eliminate the managed care companies. No one knew there would be that much savings. And a lot of it was not just direct administrative costs or the cost of risk. It was also the fact that physician acceptance went up. You had more preventive care, better frontline care in the most cost-effective settings, resulting in lower ER and hospital costs. People ask, okay, but if you don't have managed care plans, who's going to coordinate care? Who's going to provide enhanced services? Who's going to do these community-based programs? Who's going to do quality improvement? All those things can be funded directly on a non-risk basis by the state. You don't need to hire a middleman to do them. If there's an agency that can provide case management services for high-risk patients, or a team-based care program that can do consultations on complex psychiatric problems, hire that agency directly. Why do you need a financial middleman to hire them? Hire them directly by the state. And that's what Connecticut did in their Medicaid program. Now in Hawaii, as you said in my introduction, as Stefan said in my introduction, the Hawaii passed a law to create the Hawaii Health Authority in 2009, which is supposed to be responsible for overall health planning for the state and design a universal system covering everyone in the state. And we had a Republican governor at the time who refused to implement the law, even though it was passed over her veto. And a few years later, we had a new governor, a Democrat, who had been a supporter of single payer when he was our representative in the House. And he appointed the Hawaii Health Authority. And I was one of the original members. However, at the same time, the Affordable Care Act passed. And Governor Abercrombie had known Obama's parents when Obama was born. And he wanted Hawaii to be the flagship for implementing Obama's healthcare plan. So he pivoted, he threw us under the bus, took our funding that the legislature gave us, and turned to implementing the Affordable Care Act. He had no money in his budget to do that, so he went to the insurance companies for money, and they controlled the entire process. So we ended up being sidelined and not being able to implement any of the things that we recommended. So let's talk about what we would want to do, what we would still like to do if we could be activated and empowered. Obviously, the goal is the universal system covering everyone, and single payer is the most cost-effective way to do that. It gives you the lowest administrative costs and the most equity. All payer is another idea, which basically is the same as what they do in many other European and some Asian countries, where you have multiple funding streams, but you regulate them to require that they all have to offer the same thing, the same network of all qualified providers, the same benefits, the same fees, the same payment system. So it allows multiple payers to exist, but it strips them of their insurance business model. This achieves about 90% of the cost advantages of single payer. So you can start by taking the components of the health system that are under state control, Medicaid, and employee and retiree benefits, put them into a program where you have standardized fees, standardized payment, a much simpler administrative structure, and you can achieve the kind of administrative savings single payer could achieve at the state level and provide a foundation for a full national single payer program if we can get it passed. And you can show the savings that are possible by focusing on administrative simplification and getting rid of the complexities of our payment system. So we won't get cost-effective healthcare from health plans whose business model rewards denial of care, avoidance of covering or paying for the sick, and unnecessary micromanagement of care. We need universal coverage, remove the barriers to care in the most cost-effective settings, keep administrative simple and overhead costs low, stop sabotaging the expertise of doctors and driving them out of practice, and eliminate micromanagement of doctors by insurance companies. There's a lot more detail I could get into, and I'm open to questions.